Okay, so unfortunately, Dr. Neil Anand is still in surgery. So he put all the time into this. He deserves all the credit if it's good. We'd like to thank him for organizing it. And he asked us to start without him. So first, we're just going to have about a 10-minute thing on using power in spine surgery and how to protect surgeons and protect patients. And then we're going to go over some cases, about 10 minutes each, and we're going to have some discussion after each case. So hopefully we'll keep you interested and you're going to have some fun and maybe learn something. So I'm sharing my screen right now. Well, that didn't go so well. Let's try this again. Let's try to share the screen one more time. There we go. Okay, so use of power in spine surgery. Could someone give me feedback? Is this seen by
everybody? Wait a minute, Dave.
We're
I don't
not
see the
seeing it.
screen.
Dave, I'm not seeing
Okay.
the PowerPoint.
We're seeing it
Okay.
actually the first time, David.
So thanks. Let's try this again. I appreciate the feedback. Okay, we're going to go share screen, Microsoft PowerPoint. How about now?
Okay.
Perfect.
Yep, got it.
Okay.
Perfect.
You're good.
Like almost professional. Okay, we're going to talk about use of power in spine surgery. So my disclaimer is that I spent my 10,000 hours working construction. Construction is a real culture of protecting your body. If you get an overuse injury, you can lose your job, you can lose your house. It's considered wise to use power tools and not to do things manually. And it's been shown in the SRS spinal deformity surgeons that our risk of overuse injuries are way higher than the average population. In fact, neck pain with radiculopathy is 100 times higher in an SRS surgeon than the average population. And I've actually had to have surgery in my neck by Dr. Pat Johnson because I had 2 discs pushing on nerve roots. And I've had all these injuries, and there's many other studies in every branch I know of orthopedics and neurosurgery, basically saying that we are piecemeal laborers and we are at risk for overuse injuries. So here's the tools. And the important thing here is not just to put the screw in on power, but to prepare the pedicle on power. So the tool you see here at the top is a 2mm flexible drill bit. You do this on slow rotation, and you should rotate it slow enough so that one could actually see these threads move. And this is a very flexible drill bit, which we'll see in a little bit. You can feel it almost like a ball tip probe. Next, there is a dull threaded reamer. This is not sharp. This is not going to cut anything. It's going to dilate the bone to have strong bone off to the sides to capture some threads, and you put in the pedicle screw. We can see here, the flexible drill bit is really flexible. I've never seen it break. And what it does is it allows the flexibility to fall into the soft cancellous bone if you let it. And note, there's no tap here. I personally almost never use a tap putting in pedicle screws. They're sharp edges. I think that this is the most dangerous instrument in spine surgery. Now, so when we're putting in pedicle screws, we could imagine that the pedicle is almost like a pipe. It has hard cortical bone around the outside of it and then soft bone in the inside of it. So one could imagine that this flexible drill bit might hit the hard bone protecting the spinal cord. You just feel it. And as long as you are spinning the drill bit slowly, you feel this chatter, and then you feel it go into the soft bone. As long as you're not fighting against it, it will self-center into the soft bone. And sometimes it goes right in first time, and other times it doesn't. You have to fish around a little bit as long as you're not pushing too hard and you're allowing the soft bone to be found. And here's what it looks like in real life. Let's see if I'm able to get the sound off. That's kind of a pain in the neck. So in real life, this takes a little bit less than 60 seconds to screw. You know, I've been timed on this many times and I didn't know we were being timed. So this is not going to slow you up at all. In fact, I think it generally moves things along a lot quicker. So, and people always say, well, what do you do with the type D pedicle? Now, you can't put a soft, flexible drill bit against a type D pedicle or it'll just pop off the side. So instead of using the stiff lanky, you use a stiff 3mm drill bit. You know, just put it down right alongside of the pedicle. You can feel pedicle, feel pedicle, feel pedicle, feel soft bone, drill right into it. the truth is, if you're a little bit off to the side of the pedicle, there's nothing dangerous there, as long as the tip ends up in the vertebral body. And then people say, well, what about the really tough cases? So here is a kid who was done in Florida. They were done with a CT and a robot, so that must have been good. There's lots of technology. But as you can see, there's no pedicle screws from T3 to about T10 because the pedicles were too small, apparently. So we redid this. And what I'm proud of is my fellow, who was my fellow for 1 month, she put in every one of her pedicle screws on her side, freehand method, using this power technique. So you could do it even with the really small pedicle screws. Now, we work with some engineers to look at how much wobble is there. So imagine when you put something in by hand, of course, you're moving it around a little bit because we're not robots, and that probably breaks the bone screw interface and makes it weaker. And here's an example where the blue is putting things in by hand. You can see how much wobble there is. The red is putting it in on power. We can see there's a lot less wobble. And what we found out is when screws are put in on power, they're 4 times less likely to pull out clinically. It's a stronger screw, which just makes sense because it's more precise. You're not ruining that interface. So a bunch of engineers said, well, let's see what happens to surgeons' muscles. And I thought they were nuts. I'm like, what are you guys kidding me? Why are you putting stuff up in my neck and my trap? We don't use those muscles. And it turned out, this turns out all the time, is I was right and other people were wrong. And when we did the probing, tapping, and screwing manually, you could see that the EMG percentages is over 20%. And this 20% is magic because once your maximum voluntary exertion is over 20% at risk, 20% of maximum effort, you are at risk for overuse injuries. And we could see here when you use power, you were basically never above that magic 20% point. So here's another example of this. Now the dark kind of purple, this is an example of EMG going above 20% almost the whole time. And we almost can't even see this little power assisted point here. So when you use power, there's much, much less force on your muscles. And you could also see here, it takes about half the time. And here's the last slide in this. What we found out is the ECR biceps and upper trapezius and neck extensors especially were really overused anytime you put screws in by power and anytime you did anytime you did it manually and anytime you tapped manually and anytime you use a lanky probe manually, your neck extensors are exceeding safe limits. So maybe this explains why SRS surgeons have 100 times the rate of cervical radiculopathy. Now, one other thing we did is as we were doing experiments with cadavers on manual versus power, we put a force plate underneath the cadaver. And we see here using a lanky probe, all this force, it went up actually to about 40 pounds using it manually. And here was less than 5 pounds when we did it with power. And I think that 5 pounds was just my left hand on the body, stabilizing things. And one could imagine intuitively, if you want to be safe, you probably want to push towards the spine with less force. And just for residents or fellows on this call, given the choice, you never, ever, ever want to have your elbow up. That's how you ruin your rotator cuff. Many spine surgeons have had their careers ruined over a rotator cuff going bad. Given the choice, you want to have your elbow right at your side. It not only gives you more control, but it protects your body. So I started power pedicle preparation and screws to protect me, and now I use it to protect my patients. And we know this clinically. We had 6 early adopters, Hanjo Kim, a bunch of people out in New York City, put in 22,000 screws using this power technique. 99.9% of them were good with no complications, no need for revision. And in this series, we proved that using power is at least as safe as doing it manually. Now, there's a lot of other tools that we should have in our armamentarium, such as a ultrasonic cutting tool. This is fantastic. Sorry about that. This is fantastic for things like facetectomies or things like osteotomies. You cut through the bone, less force on the patient, less force on the surgeon, and it automatically causes hemostasis. So when you're doing this, you have to have lots of irrigation because it can get hot. Here's an example in the thoracic spine of taking out inferior facets. It should really take no more than 20 or 30 seconds, to take out each facet. And it's done very atraumatically. You're not hammering, you're not burring too much. Very quick, very easy, and it provides a nice anatomy to put the screws in. And it's also great for posterior osteotomies. Actually, it's almost like cheating. You just cut through the superior facets, cut a little bit through the lamina. I even use it to cut through the ligament flavum. Don't tell anyone you're not supposed to, but it's easy. Do it all in one shot. Posterior osteotomy is done. And the last thing, which you may want to try if you never have, is power kerrison rongeur. I'm not financially connected with this company. I'm not financially connected with the bone scalpel at all, but these things just work. It's very easy. And if you're just using one finger to close and open the power kerrison, you're not using your greater muscles. So not only is your hand not tired, but I think you actually have better control. And that's the end. So we will now take any questions if there's 1 or 2 minutes left before moving on to other things.
Hey, Dave,
questions, comments?
Yeah, great use of power. I just want to ask you, I've got to adopt this. When you start, do you use a burr to get the starting point, or do you just use the drill to get the starting point? Do you burr it like a little starting point first?
Yeah, Bay, you know what? You just pointed out a big hole in my talk. Thank you. Yes, of course we use a burr, and we do go right through the cortex, and it's kind of nice to see that cortical blush. And I have to put that into the talk. Absolutely. Thank you.
Oh, great. And then
David, go ahead. What is the learning curve?
For about the first 3 years, I didn't tell anyone I was doing it because I didn't want anyone hurting children. Now I have my PGY2 residents, the first week of orthopedic residency, put in screws on the first patient. The learning curve is we sit in my office together, they do it on a model, and then they do it on a human. And honestly, almost every resident puts in screws, and the success you saw, those 22,000 screws, were including residents putting them in.
And David, what about percutaneously? You do it percutaneously as well or not?
Yeah, so we're just starting to develop MIS, and I have to admit, when you do MIS and you're like hammering away, I feel like I have no control. I feel so much better using a drill bit, like we have a little bit more feel. So yes, this can be done percutaneously as well.
So how do you make your starting point? The same way with the burr, or you just do it with the drill?
Either way, I've done both. I'm still in my learning curve doing it percutaneously. And if you do it and have some advice, please share it with me.
I haven't done it. I love the technique though.
Mm-hmm.
Yeah, you just feel like you have so much more control. Yeah.
I guess I have a question on the power kerrison. Which kind of cases do you use it on? I trained with a guy who used the power kerrison on, and he did a lot of redo lumbar degenerative decompressions. And my experience with it is it's a yes or no thing. You push that button and you're taking that bite. Whereas when you're doing a manual kerrison, if you start to take the bite, you think you may have a little bit of dura in there, you can kind of back off and maybe not get a big dural tear. And my experience with the power kerrison, at least in lumbar degenerative, particularly redos, it was kind of a dural tear machine.
Yeah, fair enough. If you pull down slowly, then the instrument moves slowly. So I think you can have that amount of control. If you pull really fast, it's extra strong. So I don't feel like I give up very much control on it. And the times I like it the best, honestly, are for decompressions, because all you're doing is cutting bone, boom, 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 boom. Yeah, and like anything, it has a learning curve, and some people like it and some people won't. I'll never go back. I absolutely love it. I feel like I have a lot more control.
Dave, to follow up on that question, I think this is the question that Scott's asking, and I'd like to know this too. There's a difference between power assisted. It's like, power steering, where you actually are, you still have a little feedback. It's not off or on. Are these kind of what I would describe as these characters, like, meaning that, it's like it's like a bicycle, right? It's like an electric bicycle. Is this more like an electric bicycle where you can kind of have some feel and it kind of decreases the amount of force that you need, or are these? So
you have a lot of feel. You have a lot of feel with it. It is not on off. Depending on how hard and how fast you pull it is how hard and how fast it closes. I find that there's a great deal of control and sensory feedback.
And one thing one thing, Dr. Skaggs, that I think you brought up before with me was I explained to you that some of the power, when I've tried using power here, our tools are very long that we had. And you actually, so you need to incorporate this into your talk as well. You have special made tools that are shorter in length, where I think that ergonomically as a surgeon, if I have to get on 3 steps to use power tools and my patients, far down, then I actually have cervical flexion, which is also really bad for my cervical spine. And so you have special made shorter tools, which are ergonomically much, much more favorable for you.
Yeah, I'm convinced that the shoulder surgeons are paying off the spine instrument designers to ruin all of our shoulders. Yeah, if we just cut the length of all the instruments in half, we'll have a lot more control and a lot longer life on our shoulders. So,
well,
thanks,
that's the difference between working in California and Texas. Each one of our patients is at least 18 inches deep.
Hey, Dave, someone's asking you, who makes the power kerosene?
Asculp, I think is the name. I might not be pronouncing it correctly. Asculp. If you want to, you could just search my name.
Escalab.
Yes, thank you. I'm not very good at speaking. Yeah. Or you could just search my name in Google Scholar. There's a paper on it. No.
David, in the paper, do you give all the specs as far as the revolutions? You said it was a 2 millimeter flexible drill, where you can get all this stuff, because I'm fascinated by it. I'd love to try it.
Yeah, so for years, honestly, I stopped at Home Depot and just got that stuff. And now, am I allowed to say the name of the company that makes the reamer? Zimmer Biomet makes this dull reamer. If anyone on the call wants it and can't get it, text me or email me, I'll get it to you. The truth is, I just use a 2 millimeter Synthes drill bit. The drill bit itself isn't that important. As long as it's 2 millimeters, it's flexible. The reamer is the only thing that's really custom made. Because I don't like the sharp tap. The reamer just dilates the bone a bit.
Wait, the first drill that you showed was had a little bit of a ball tip. It had a ball tip and then a shaft, where the cutting portion of the drill was about, I don't know, 8 millimeters or so. Is that's custom, or is that just available?
So that's custom. Oh, I'm sorry. It is available. That's patented. That's for sale. It's not needed.
Okay,
as
I
a
see what you're saying.
2.4 millimeter tip and a 2 millimeter thread. All you really need is a 2 millimeter drill bit. That's all I use. Yeah, I'm just saving money. Be simple. Go to Home Depot.
Got it.
Dave, are you
Home
using
Depot.
any imaging modality too, or is this all freehand? And if you ever breach, how do you address that? I mean, do you just keep using your anatomic landmarks with your power, or how do you kind of recoil after a breach?
I probably do 98% of my screws freehand, and then afterwards check with PA fluoroscopy image. And if you feel that you've breached, then just start a little bit more lateral. I'd feel like I'm hogging the time. I should shut up now. TK, you should do your case. So happy to chat with anyone any other time about this. Thanks for listening.
It was great, Dave. I know you have a big call and some other meetings to get to as the head of our spine center. So keep at it and keep advocating, and we'll talk to you later. Thank you so much.
Thanks.
Dave. Thanks, Dave.
Have a good day. Thanks.
Our next, so for the next 40 minutes, we have case presentations. It's a collaboration of all the ortho and neuro surgeons at Cedars. This is usually where Neil comes in and says something extremely witty and funny, but he's not here. But hopefully he's watching, or he'll see the recording. I'll start off with mine first. Neil asked me to talk about robotics and navigation at Cedars. Can everyone see my screen?
Yes.
Okay, great. So we started using Medtronic Mazor robotic assistants in 2019 December. So we're broaching on almost 2 years of experience. And in my practice, in my partner neurosurgery, Pat Johnson's practice, we use a lot of O-arm with the robot instead of the fluoro assist. So these are my disclosures. What I have are 2 cases that kind of highlight how we're seeing this almost 2 years out with our experience. And I think every new technology that we've incorporated, whether it's navigation, robots, we try to standardize the workflow, and we try to think each of the steps through. And as I was making this talk today, I was trying to figure out, how do I really think about incorporating robotics and the navigated O-arm into my cases? And this is kind of what I came up with. This is actually the first time I'm presenting this, so by all means, it's a rough draft. But when we're doing instrumented cases, the inner body is obviously step one or step zero, but that doesn't usually involve robotic or navigated cases. It's a lot more the O lifts, the A lifts, the D lifts, whatever ifs du jour. So that doesn't really count as a major step, but that is usually the first part of our case. The second part is then a posterior-based approach with instrumentation. And the way we see this in our practice is a three-step process. And when everyone sees it simplified as a three-step process, all the teams start understanding where they need to go. Step one is usually a robot mount. In my two cases, we'll kind of highlight this over and over again. We mount the robot, we get an O-arm image acquisition in a pretty quick fashion. Step two is many steps within it, but they're all happening at the same time. And I'll kind of go over the intraoperative screw planning that we do. We do not do a lot of preoperative planning on a Sunday afternoon while we're watching football, which was what was told to me by others. We remove O-arms, we calibrate instruments, we upload the plan. This is all happening in step two. And then finally, step three is screw insertion or execution. So here's a classic patient, a 73-year-old, operated on by a lot of my senior partners. I inherit with more or less kind of that end stage look. A lot of back pain more than radiculopathy, but radiculopathy nonetheless, some spondylolisthesis at multiple levels, not a big deformity case, more degenerative, and having had multiple surgeries. What you see on the MRI is bilateral foraminal collapse, multi-level degenerative disc. And these patients go through quite the ringer before, with me, before they're decided to have a surgery. And in my hands, I'm finding more and more, this used to be done 10 years ago when I first started, but nowadays this is more a lateral trans-psoas, multi-level, indirect decompression, posterior spinal fusion. So as we take this case through that robotic navigated case, and you can pare this down to a 1 level, or 2 level, or 3 level. But in our case, stage 1 is obviously the inner body cages. The foraminal height is restored, lordosis maximized, and that is kind of the first part of the case. Step 1 then, so that's the anterior reconstruction. Step 1 of the robotic portion of this is with me checking my texts and my emails over off in the corner as I'm catching up with what I missed with everyone who's trying to contact me. But at the same time, we have a team that's doing other things. We have the nurses and the scrub techs that are prepping and draping. We have the navigated robotic consultants that are mounting the robot. Then I come in, put the percutaneous pin in, O-arm spin. It's a very kind of quick process. Step 2, that process that happens with a lot of teams coordinating around. This is me with the navigated robotic consultant who puts a USB stick inside the O-arm workstation, captures the image, and brings it over to the Mazor. While that's happening, what you see is that the radiology tech, we're a navigation center, so the radiology techs are extremely well trained and very independent. They're already pulling out the arm as that's happening. We feed the image into the robot, and during that time, as the navigated arm is coming out, we're starting to pre-op plan our screws, and this is all happening in a very coordinated fashion. This is George Hanna, now our newly minted partner, but our spine fellow usually comes in, scrubs in and starts getting the patient prepped, takes the drapes off, calibrates the instruments. And so this is all happening in a very coordinated fashion. Surgeon checks the final plans. We upload the images to the robot. And then step 3 is the execution. Basically understanding what we're working on both sides. We have the plan all set. The navigated robotic arm really does cut down on the fiddle factor, which we used to have with navigation about the ideal trajectories. And ultimately what we plan is what we get. So as we take this to our second case, one would think things would be different for a bigger adult scoliosis or deformity case. But what my message is if the workflow is good and compact and everyone knows their plan, then it's basically a very standardized process And that's what you want to do in order to improve your overall efficiency. So here you have a 58-year-old female, thoracolumbar back pain, worsening function, coronal imbalance on the coronal plane. She's off to the right, big thoracolumbar curve, 45 degrees. The sagittal alignment isn't terrible. Doesn't have a big mismatch. Slightly positive at 3.9, but at about 60 years old, it's kind of age appropriate, one would say. Here are EOS films of her standing, no major appendages issues. And our plan for her was a short stop TA to pelvis instrumentation. So here comes the anterior reconstruction again. In our case with big scolies, we usually do a 2-level A-lift from the front. I augment it with an ATB plate, a titanium plate for unilateral pelvic screw. This is our FRA interbody grafts with Synthes screw washers for a stop of the 4-5 graft. So that's part one, but our actual screw instrumentation is that same process, same 3 steps again. You come in, you dock the pelvic pin into the PSIS, image acquisition, intraoperative planning, bring out the O-arm, screw insertion, effectively, boom, 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 L4 to pelvis, off we go to the next. Second spin, we move the clamps to the midline spinous process. We always include the last screw as part of the O-arm spin to check internally that our accuracy is correct. And then again, image acquisition, intraoperative planning, pull out the O-arm, coordinated fashion, screw insertion, boom, 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 T11 to L3. Third spin, up to the UIV. Once again, change the clamps, put them up higher, include the last screws for the internal check. Image acquisition, intraoperative planning with the NRC, fellows getting the robot ready. We come in, the screws are already predetermined. The scrub tech knows exactly what we need, screws insertion. So this is actually turned into a surgery that we're almost getting to almost as efficient as when we were doing it without the robot. We're not quite there, but we're definitely getting to a point where at least our clinical outcomes are doing very well. This is our 1-year follow-up on our lady. And ultimately, what we realize with our experience is standardization of workflow is absolutely important. You have to think about the big picture and then bring it down to something that's easily discussed with your teams. So we see it as more image acquisition, plan the trajectories, execute. And coordinate. If everyone does their job, just like on the football field or any sports event, if everyone does their job and you have a good coach that's coordinating, you can get just as fast. There's not a lot of preoperative planning. Everything is done episodically at the time of the OR. There's a lot of coordination, workflow disruption opportunities, but ultimately we've been pretty happy with our experience. So thank you.
Awesome. Terrence, okay, so I'm going to pose this question, and we have Izzy here too. So that's a lot of technology, certainly a beautiful surgery. Now we had your talk, which was the amazing technology, the $1 million robot. And then we have Dave's talk that was like, hey, just go out in Home Depot and buy a 2mm drill and just use that. So tell me, like, what do you like? How do we, put these two together? I mean, what do you feel that, let's say, the robot gives you that advantage? Like, what is it? Is it just safety? Or are you able to place longer screws, more correction? Like, what does the robot, provide for you?
So, I think Dr. Lieberman will provide that 10,000-foot view as to the value of robots, because that's what is kind of exciting about using it right now. We're in the frontier where we're understanding things. When you're looking at direct costs and you do compare a robot to a Home Depot drill bit, by the way, I'm sure Dr. Skaggs didn't want everyone nationally to know or think that he just goes to Home Depot to buy his drill bits to use in the OR.
Yeah, I don't think that's what we should do. I would say at least, spend like $20 and get one that's medical grade.
So when all new technology, right, just like the initial iPhone, just like the initial Apple computer, the prices were outrageous, 4K TVs. And what you see is initially the adoption from a cost perspective is not going to make sense. So that's why you have that whole curve of early adopters, late adopters, so on and so forth. But the value is, as I see it, is simultaneous surgeries being done with multiple robotic arms, all in the name of standardizing spinal surgery delivery, trying to get at clinical outcomes to reduce length of stays, take-backs, revisions, and ultimately that end value, when we all see the bundled payment model coming on, the end value proposition that this robotic technology can enable our spine surgeons and our patients to have, I think that's where it's going to really be attractive. But, you know, as you see it kind of at direct cost level, it doesn't really make sense. What do you think, Izzy?
So, first of all, great talk, Terry. That was really good. I love the work you guys are doing on the workflow of it. I think that's critical to establish those things. Just for the sake of clarity, I do my planning after the Cowboys lose, not during the game. So I just want to make sure that everyone understands that I pay attention to my planning. We're in a real privileged position right now. There is so much technology out there that we have not taken advantage of. Simple technologies and complex technologies. But I have no doubt that one day we're going to have an automated robotic arm with a flexible drill with virtual reality goggles that we're going to be sitting at our home somewhere watching the surgery being done that we predetermined was the most appropriate for that patient. That's what we're going to see in the future. And I think as long as we're all thinking about these things and critically analyzing it, it doesn't matter whether it's navigation, robotics, augmented reality, flexible drills, ultrasonic bone scalpels. It's using the right tool for the right reason at the right moment in time for that patient, because every single case we do is going to be a little bit different.
Excellent. So let's move on to the next talk. I think it's, is it Tiffany Perry?
Yeah, I think it's me. Okay, can everybody see my screen?
Yes.
Okay, great, perfect. So Dr. Anand asked me to just give a talk on spine tumor. So I'm going to go through this case, which was a tough case technically, diagnostically pre-op as well as intra-op. So this is a 37-year-old gal who presented to me. She was woken up from her sleep in the middle of the night. I think it was around like 2 a.m. by this explosion at her temple. She had the sudden onset of right facial numbness, feeling of blood rushing to her head and the side of the body. She had extreme pain on the whole right side of her body for about 10 minutes. She woke her husband up and no loss of consciousness, no bowel or bladder incontinence because they initially were concerned about possible seizure. She did have nausea, had diarrhea. She started experiencing some numbness and tingling in her fingers and toes. She felt to touch that the back of her head felt very cold, and then her right ear felt very clogged. After this, she had developed an imbalance for about 2 weeks, and she went to the hospital that early morning to be evaluated. So her exam, as far as the exam that they got when they got to the hospital, pretty unremarkable. By the time that she saw me in clinic, she was completely full strength in her upper extremities, completely full strength in the lowers. Her sensation was intact, but she still had the sensation of cold along the back of her head. All her cranial nerves were intact for 3 through 12. She had no drift, but she was unable to tandem walk. She actually looked very unsteady, and she's actually a super fit person. She's a volleyball coach. She has 3 children, very highly functioning person, unable to walk on heels, unable to walk on toes, and appeared very unsteady when she was walking. So when she went to the outside hospital, she was from actually out of state. So she went to the outside hospital that early Monday morning. By the time she got there, the CT head that they obtained was initially read as normal. But as you can see, this is not a normal head CT. I put up the sagittal view of this as well. So you can see along here that she's got this large mass or large something here at the foramen magnum, what appears to be dorsal to the cord and inferior to the cerebellum. And then on the axial slice, this is the posterior arch of C1. You can see spinal cord ventrally and obviously some sort of a dorsal mass here. So they read the CT as normal and didn't show a stroke or a hemorrhage. So they decided to do an MRI brain without contrast. And that was when they actually spotted something and they thought, uh-oh, something's going on. They decided to get an MRI brain and then send her towards us. So here was her contrasted MRI, which we actually obtained here at Cedars. So this is the sagittal view zoomed in, and you can see here's pons medulla coming down into spinal cord. You can see spinal cord appears thinned out here. I'm going to show you some T2s as well. This is the non-contrasted T1, and you can see there's this mass that's dorsal to the cord spanning all the way from the foramen magnum all the way down to the top of C3. And then here's the contrasted study. And so you can see there's what I call not true enhancement, but just a blush of enhancement here along this dorsal aspect. On the axials, you could see a few blood vessels coursing through this lesion, this tumor, and sort of the expansile nature of it. So then here is the T2. And I think the critical thing is actually the T2 and trying to figure out the exact location of this tumor. And so the tumor abuts all the way up to the top where we're going to see it abuts near the cerebellum, coming up here with the cystic portion along the dorsum of the cord. And then along here, it almost makes you feel like it's coming out from the central canal, right? It's the way this T2 looks. It's a really nice view of trying to figure out, is this some sort of an intramedullary exophytic lesion? Is this, truly intramedullary that's out? Is this some sort of complete, extramedullary lesion? So I think these images were really critical in trying to look at the lesion. So we called this an intradural extramedullary versus intradural intramedullary with exophytic component, ultimately thinking based off of the T2 that this really was truly an intramedullary with exophytic component. So we took her to surgery, I used the ultrasonic drill to do a suboccipital crani just to get enough exposure. I'll just come back here just to get enough exposure here at the foramen magnum dorsally to get a nice view so I could peel down rostrally first and then work my way down. So then also did a C1 to C3 LAMI so that we could have a nice view of the tumor from rostral to caudal. So it came back as a WHO grade 1 subependymoma. So obviously for this complete resection is going to be the best thing for her not to have anything that potentially could grow in the future. We worked first rostral to caudal and then lastly started working on the intramedullary portion with the fine tip ultrasonic aspirator. She had stable neuromonitoring throughout the case. Post-operatively, she was completely full strength. She does have some residual right hand numbness, which she had pre-op. We didn't get that back. It's been the same, but she's completely returned to CrossFit, coaching volleyball, and full-time mother of 3 children. Here's her post-op MRI initially. And then here is our 2-year post-op MRI, no contrast enhancement, no residual tumor, and cord actually has returned to a nice, pretty normal caliber, which we were pleased with that. Any questions?
Yes, so Tiffany, how is that? That's so it looked like that was very, kind of posterior and cranial. So do you take the base of the skull off to get to that?
So I did. You can see here just sort of my lines. I did a very, very narrow suboccipital crani and just enough to be able to view superiorly with the microscope up cranially, see cerebellum, and then peel that tumor down, which then brought me to that area. That's the safest stuff. As my chairman always taught me, that's the low-hanging fruit. That's the stuff that you want to get out first. And then peel away as much tumor as you can. But then once you hit that portion that's really coming out, from what we believe was the central canal portion, that's where you really want to take your time. It takes about basically 90% of the tumor comes out in 10% of the time. And then that 10% of the tumor, you've got to take 90% of your time to get. And so that's the part that you've really got to be meticulous in making sure that you don't overshoot on the resection through the intramedullary portion.
And the presentation.
So the great case, beautifully presented. Can you hear me?
Mm-hmm.
Yeah, we can hear you, Jens.
Beautifully done. So the question I have for you is, do you use any image guidance in surgery? Do you use ultrasound, something as a reference? Or is it just basically good old surgical feel, touch? No Izzy, Terrence, Hyunbei, Dave Skaggs, high-tech tools whatsoever. Good old surgical magic.
So do I use that stuff? Sure. I think if I had trouble localizing or had a very small tumor, but this was something spanning from the foramen magnum down to the top of C3. So no, I felt very comfortable doing good old fashioned neurosurgery.
Love it. That's what I hoped you'd say.
No image guidance. Lord knows if I needed navigation to find this, I shouldn't be operating.
No, but I was all joking aside, I was thinking about margins. And tell us about vascular structures. Do you take any MRAs, any intraoperative Doppler to make sure that you're staying away from vertebral arteries, et cetera?
No, I wasn't worried about that at all. I mean, we can obviously see pica as we looked up. You'd see your picas coming out, but not worried about the vert at all based on the pre-op imaging. It didn't medialize enough that I was worried about that. So yeah, felt very comfortable with that.
Lovely. Well done. And how often should a patient have an MRI after surgery, after a procedure like this?
It's a very good question. So with a subependymoma and what we thought was a gross total resection, as well as a radiographic resection based off her post-op day 1 MRI, I believe I got my first post-op MRI 6 months post-op with a WHO grade 1 subependymoma. I did another one at a year. And then we went to a year out at that. So we're 2.5 years out now from surgery, and I think I'm letting her go 2 years now. It's a low grade, slow growing tumor. And to be honest with you, with the lack of enhancement, with only that blush at that dorsal part, I think it's going to be very difficult to spot something except on a T2. I actually think on the T2 weighted imaging is probably going to be what I'll best see it as.
Tiffany, one of the one of the people in the comment section wanted to know about what your thinking was with laminoplasty, posterior fusion with the laminectomy. When do you do it? When do you don't?
Yeah, I think that certainly I could have done something like a laminoplasty in this. I don't really think there's much of a utility in a young 37-year-old gal who's a very, strapping person. She does CrossFit. She's very, I don't feel like there's a big utility to doing a laminoplasty in this. She had good alignment pre-op. I wasn't worried about her kyphosing forward. She wasn't getting post-op radiation. So there are all the things that we would worry about that could potentially cause her musculature to degenerate or the facets or discs to degenerate. I wasn't really stressed about in her. So I think for the pain in the ass that it potentially would be to do something like that, I don't think that the utility was here for this particular patient. Could you? Sure. Would I? No.
But what you're saying is that you don't feel that she was at risk for kyphosis,
No.
and therefore, therefore, but if somebody was at risk for kyphosis, or you thought that maybe older patient, would you consider
Sure,
that?
if it were an older patient that I were concerned about that, absolutely. I think that there's nothing wrong with that, as opposed to fusing them. The downside with when you put in hardware in these patients that are tumor patients, I really worry about post-op imaging, right? I don't want that artifact of titanium in there. I want every ability to be able to see and follow the tumor.
Okay,
sure.
In the interest of time, we're running a little short. Let's get to Dr. Bay's presentation.
Oh, sure.
Or is it Pat or Dr. Bay? I'm sorry.
I think it's Pat.
Pat, you want to go ahead and
Sure, I can go ahead. And while I'm loading up my talk here, is that Tiffany, that was a great case. And to answer Jens, you would probably like being a neurosurgeon, because this is really a technically oriented dissection that Tiffany had done a beautiful job on. And when you get inside of somebody's spinal cord, it really depends on the tumor type And then it becomes tissue planes, and it's establishing that. It's finding it in ependymoma. Fortunately, it has tissue planes, and from the looks of this case, the lady's probably cured. So it's a lot of back to being a real surgeon is what it's about. So, are we ready to go here, George?
Yeah. You guys
Okay.
can hear Dr. Johnson, okay?
Yes. How are we doing?
We can hear you fine. Go ahead.
Okay. All right. Well, thank everybody very much for their great talks. And Neil, I'm not sure what happened with Neil. I think that he put together a great program here. And I'm going to present something a little more expanded than a single case, and kind of talk about some of the thoracic disc surgery that we've done with endoscopy. And actually, we had a major publication that George had put together. George Hanna, our past fellow and new partner, had put together. And it's about how to treat some of these complex problems in the thoracic spine when it comes to myelopathy on most occasions. Where am I going here, George?
Click on the arrow.
Click. Okay, thank you. And these are my disclosures, which none of them pertain to this talk. I'm going to talk about thoracic disc surgery. It's a little bit of an evolutionary talk is the way the paper was written, and actually the whole data set was collected over a 19-year period of time. But thoracic disc problems of this kind of nature are certainly challenging problems. Most all of them need to be done from the front side simply for appropriate safety. Lateral approaches can be done, but none of them really from the back. Some of the history goes back with thoracoscopic surgery that Dan Rosenthal in Germany had done some of these first cases, and I met him shortly thereafter. And Curtis Dickman in Arizona had been a big proponent as well. And these type of operative procedures are done through the chest with an endoscope. And the Texas guys certainly know that John Regan was in Texas and had done a lot of these. And when he came to Los Angeles, we had a lot of collaboration and wrote some papers together. But it's for an infrequent problem. Some of the early instruments that we used were fairly limited, and we developed these things. We had some other experience along the way with doing endoscopy in the thoracic spine, with doing sympathectomies. It gave us some experience of doing things in the chest, which were just not common to our training in either neurosurgery nor for orthopedics and spine surgery. And we'd published a number of papers along the way, kind of an evolutionary process. In fact, Rod Askuyan, when he was at Virginia as a resident, now at Seattle Science Foundation, had participated in a number of these papers as well. And it was really kind of an evolutionary process. And the first generation of these procedures that we used navigation in some of the early days, but the first days we didn't use any navigation. We would open the patient up, we would put endoscopic ports where we thought they should be. We did intraoperative x-rays, but when we started applying navigation and spinal stereotaxy, these were in the late 90s when we first started doing some of these procedures. And we did some research work of how to navigate off the front of the spine and use fiducials back before we had CT scanning and automatic registration. That's hence the black and white pictures, but we eventually published what we thought was kind of a second generation of this technology in 2005 after we'd come to Cedars and had our experience with thoracic disc using image guidance. And so we've further expanded that into new applications. And since the invention and the use of the intraoperative CT scanner with immediate and with the speed of light registration and being able to apply navigation to virtually everything that we do in the spine, it's given us the ability to treat some of these problems on a fairly regular basis and with precision that we never had before. Being able to use an endoscope with a image guidance and marry them together into a minimally invasive procedure. The use of some of the different tools that we use, we helped develop some of these which have gone on to become a little bit more sophisticated than what you see with the reference frame. attached to some of the long drills, and we would put a reference frame on the back of the patient, and we'd place portals in different locations. We were able to place all of these with the navigation technology rather than just guesstimating where they were. And we asked the question, what should we navigate? And we do all of our instrumented cases really with navigation these days. I think we're going to move more into some of the more common operative procedures that we do for decompressions, and we have done this. Third generation is marrying all of these together, and we've completed the integration of the computer-guided navigation, and we're working on workflow with these, and it's now essentially a fully integrated system. We put together our experience of video-assisted thoracoscopic spine surgery from 19 years, and it's kind of, as I said, in the third generation at this point, and it was a case series of 190 patients, and you can do the math. What we do. This is what the operating room looks like with a lot of monitors. There's an endoscopic monitor. There are computer monitors, and we find ourselves looking at the computer monitor sometimes more than the actual endoscopic monitor. This is a schematic which, interestingly, we needed one, and I kind of drew this out for the publication that we put together. But these are some of just the navigation tactics that we use. If we drill through the rib head, undermine the vertebral body, and we have the endoscope. We have the patient in a lateral position, and it's about 15 degrees off the midline of we do this. And these are some of the trajectories that we'll see intraoperatively from our navigation, and we can begin these from the skin incision all the way through the decompression across the opposite side. And these are some of the decompressions for fairly large, sizable tumors like this, which, sorry, that skipped ahead. But this is a patient actually operated on before, sent to us, was deteriorating. And these are some of the decompressions that we see post-operatively to be able to remove sometimes fairly large masses that are usually calcified. These are some of the data. I won't go into some of these at this point, but these are the levels that we've done. This is the operating room setup where we have the C-arm, various workstations with the video and the computer and the endoscopy, and the way the nursing staff is set up. The patient's placed in a lateral position. We put a reference frame on the spinous process. We do an intraoperative CT scan. This is the last year's chief resident putting the reference frame in place, and then we can navigate the entire procedure as though it were going to be done through a thoracotomy. This is the intraoperative CT scanner going into place. These are the navigated incision that we can pick out. Sorry about that. Exactly where we're going to go through the chest wall and set up the navigation from the very outset. Occasionally, and in some selected patients, we will do mini open thoracotomies. We like to do the endoscopy as much as we can, but we do the operation pretty much the same way. If we're going to do a mini thoracotomy that we have our thoracic surgeon help with, and it's essentially done the same way, but we'll use the microscope. The most critical tool that we use is a navigated drill. And this is where we're basically undermining the spinal canal and decompressing the spinal cord in patients that are oftentimes fairly debilitated from their problems. The open thoracotomy is oftentimes done in some of the lower segments of the thoracic spine where the diaphragm is sometimes a problem. And in older patients, sometimes we will do it if it's a single level, and I actually think we can do it faster and safer than the whole setup. And that's what I'm going into a little bit here. Some of the congenital stenosis patients with OPLL, we will still do most of those with the endoscope and thoracolumbar junction, just because of the diaphragm is a little bit of a challenging place to work at, and it's just easier to do these with a small open thoracotomy. The most important thing is safety, and I think that actually the navigation provides safety that it actually never did before. I'm going to show one short case here. Is actually a 39-year-old businessman, wife of a physician. The patient had worsening gait and imbalance with paresthesias, and he is found to have a interesting set of multiple thoracic disc problems, but the symptomatic one was at the T1011 level. He has a signal change in the spinal cord. He also has one at the level below, and a fairly severe stenosis on the axial views. And I'll try and play the video rapidly if I can. But the posterior, the spinal cord is above. This is a disc that's below. We've actually already done a lot of the bony decompression here, which is the rib's been removed from up here. The disc space is down here. We've typically removed just posterior 1/4 of the vertebral body. We can navigate across the side of the spinal canal, and we will see the ventral dura above and removing the tumor. This is actually a fairly soft tumor. Many of these, they're calcific. We end up having to drill the whole thing out, and some of them are soft. So it's interesting is that the CT scanning does not necessarily tell us the consistency of these lesions until we get there. There are some of them that look like they're completely calcified. They look like they're going to need to be drilled out, and some of them are fairly soft, and there's enough calcification within them that they look like they should be densely calcific disc lesions. So anyway, we'll keep going. So this is a post-operative imaging. It has a complete decompression. He still has a signal change in the spinal cord. Clinically, he significantly improved. And I hope you enjoyed this walk through the history of navigation and endoscopy in the thoracic spine. Thanks.
Hey, Pat, beautiful talk. I actually think that, it's kind of like cardiothoracic surgery in the sense when I see this, every time I see this, I'm like, this is really technically amazing surgery. You got to be very skilled. I'm sure there's a large learning curve. I look at this and go, it's like, bringing back to when I looked at the cardiothoracic surgeon going, man, those guys are really doing something. But, my question is that I almost feel like I've seen this happen to laparoscopic A-lifts. Like we had this kind of minimally invasive laparoscopic A-lifts, and then we started doing mini opens, and then we kind of never went back. And I'm thinking about these kind of thoracic disc herniations, now that we have this kind of, lateral approach with the small retractor with, like the X-lift retractor. And, people have started doing like mini thoracotomies and just doing it open or in between the ribs. I mean, do you think that, this is the way to do these? I mean, or, for you, I mean, would you, think these days, would you ever try to do it kind of X-lift style with like a little mini open retractor without the endoscope and, approach it that way?
No, that's a great question, Bay. And I think you're absolutely right, is that, this isn't for everybody. I've done them kind of since day one, and maybe you could call me a dinosaur. There are a few of my fellows that do them. A lot of my fellows have gone on to kind of develop their own mini open approach to doing these, and with some of the X-lift, D-lift retractors through the chest, simply doing them. They've learned how to do them from the front side is really the most important thing, whether you use an open approach or whether you do it with endoscopy or not. I still do them as a lesser number of them, just because I like doing them with the endoscope. And I mean, we put several small incisions that are 1-inch incisions in the patient. But I think, it's kind of like using navigation or robotics, and how do you put pedicle screws in? I mean, some of our earlier talks were about it. Do you put them in by hand or do you use navigation? And, the endoscopy is simply a visualization means. And when I do them as mini opens, I just use a microscope. And in some respects, I can say I like that better. I can do it really, really fast. Hemostasis is much easier. You don't have also the triangulation and the fulcrum effect of doing an operation through the chest wall. If you have an open thoracotomy, you can put all the instruments you want in at every angle. And we only do small, I call them boutique thoracotomies. I mean, they're
Yeah.
small incisions.
Yeah, I mean, the neat thing is you're doing the exact same on
Same
the
operation.
Henry Bowman did 40 years ago. You're just saving the patient from that big rib spreader, and all the recovery and the pulmonary complications. So
I forgot
it's really
what that,
the quintessence of minimally invasive surgery.
yeah. I forgot what that rib spreader is, but that
Yeah,
is
big
like, you
instrument.
bring that in there and you're like, whoa, this is serious surgery.
Oh,
Yeah,
they're
it's like 10 pounds. Like it's like a whole chunk of metal. You're like, whoa, what is this? But with that, I just want to say this is the perfect ending because I had a beautiful arthroplasty case, but you're just going to have to come back next time to see it because it's 6:00. I'm sure we'll be back and we'll save that case.
You guys did a great job. Thank you very much. It was a great program. Tell Neil he missed a good one.
Yeah, he did.
Yeah, tell him he's in trouble.
Have a good night, everybody.
Thank you,
Awesome
Cedars.
work,
Bye, guys.
team.
Right, good night,
Have a good
Good night,
evening.
everyone. Thanks for being here.
Bye-bye. Don't forget
Neil
to
who?
sign in for your CME.
Neil who?
Yeah, exactly. Neil Hu. That's perfect. That's perfect.
Neil Hu.
Great
Make
job,
sure that's
guys.
on the recording.
Great job, Neil. Thanks, Neil.
Yeah.
Neil,
Yep.
Tell
See you,
Neil
Neil.
he did
Thank
a
you.
really, really good job.
Bye
All right.
now.
TBI.
Good
Does
night.
it. Thanks, guys. Appreciate it.
good night.
All right.